Hello, I'm Dr. Joe Vicari, Chair of ASG Practice Operations Committee, and I'm here today with Dr. Brad Bowyer from Rockford Gastroenterology Associates. Brad's here with me to share his insight and thoughts on his recently published article in GIE entitled Outcomes of Symptom Screening and Universal COVID-19 Reverse Transcription Polymerase Chain Reaction Testing Prior to Endoscopy in a Community-Based Ambulatory Endoscopy Center. Brad, thanks for spending time with us today. My first question is, what prompted you to perform this study, and please review the results of your findings.
Thank you, Dr. Vicari, for taking your time for this interview. Of course, as you well know, endoscopy was allowed for only emergent or urgent cases throughout the U.S. during the height of the pandemic. In the state of Illinois, on May 11th, elective procedures were allowed if a real-time RT-PCR status was negative, having been obtained 72 hours prior to their scheduled procedure. As part of our resumption of procedural activity, we adopted the ASGE risk screening questionnaire, which can be found on their website at www.giejournal.org. We evaluated 1,000 patients who had scheduled examinations from May 22nd through June 28th of this year. They had successfully answered yes or no to each of the symptoms known to be associated with COVID-19 virus infection, and whose nasal pharyngeal RT-PCR obtained at our on-site testing facility was valid for interpretation. Our goal was simply to determine the incidence of COVID-19 infection and the predictive value of reported symptoms. Significantly, 0.8% of our patients tested positive for COVID-19, while the community percent positivity rate was 8.37%. We found the predictive value of a negative risk screening questionnaire to be 99.43%, while the positive predictive value of the questionnaire was low at 2.46%. Although the negative predictive value was quite good, RT-PCR testing was invaluable in preventing 5 asymptomatic patients from undergoing endoscopy in our ASC. 119 patients reported symptoms. Similarly, 119, or 12% of our cohort, who reported symptoms but tested RT-PCR negative and were allowed to undergo necessary pre-procedure evaluation who would have otherwise been excluded without RT-PCR testing. We concluded from this data that symptom-based screening alone should not be the primary pre-procedural assessment tool in selecting patients for undergoing endoscopy during the COVID-19 pandemic.
Thank you, Brad. My second question is, what could explain the difference in infection rates between your patients and the community at large?
Indeed, self-selection and health consciousness are probably two primary explanations for the discrepancy of percent positivity within our cohort and that found in the community. In the former, if the patient feels ill, they're likely to not schedule an elective procedure, which would escape our COVID-19 testing. Also, we believe that perhaps patients who are health conscious may practice social distancing, avoid contact with others who may be infected, wear a mask more readily, and use frequent hand washing, and as a consequence be less likely to be infected.
Thank you, Dr. Bowyer. My next question, Dr. Bowyer, I recognize there is no previously published data on the predictive value of symptom screening, but are there reports in the literature regarding pre-procedure RT-PCR positivity rates?
2 coastal academic centers, Dr. Podboy and his group in Stanford, California, and Dr. Dollinger and colleagues at Mount Sinai in New York City, reported less than 1% positive rates in their patients undergoing procedure. This was also markedly lower than found in the communities they served.
Brad, my next question. Were the symptoms reported in your patients highly suspicious of COVID-19, such as fever, cough, or respiratory symptoms? what were the most common symptoms reported by your patients?
No, actually, the patients did not present with symptoms highly suspicious for COVID-19, Dr. Carey. The most common for all age groups were, perhaps as expected, nausea, vomiting, and diarrhea.
Follow up to that, were there any unique findings within the RT-PCR positive patients, and how many patients were RT-PCR positive?
Indeed, 5 patients were asymptomatic, and 4 of these 5 patients were 45 years or younger in age, which in our cohort, patients under 45 represented only 13.9%. This suggested to us that perhaps there was a higher incidence of asymptomatic infection in younger individuals. Of the 3 symptomatic patients, 2 reported only nausea, and the third reported a sense of loss of taste or smell, chest pain, and sore throat.
Does pre-procedural screening and RT-PCR testing create barrier to procedural access, and if so, what is the potential negative impact?
We believe that pre-procedural testing does create a barrier to endoscopic evaluation. Anecdotally, we found that patients were reluctant to undergo RT-PCR testing, or they were unable to quarantine for 72 hours, and they found scheduling an additional test, the RT-PCR testing, related to work or child care activities. Now, the significance of this was highlighted by Dr. Mering et al. In the UK. They recently reported in Lancet Oncology an expected 16% increase in colon cancer death due to delays in diagnosis as a result of the pandemic.
My next question, Brad, do you foresee a time when universal RT-PCR will have less value or no longer be indicated prior to endoscopy?
Yes, as the disease prevalence approaches 0, the positive predictive value of an RT-PCR likewise becomes very low, and if positive in a region of nil prevalence, would likely be a false positive in the absence of high risk of suspicion or risk of infection for the individual being tested. Now, vaccines, proven medical therapies, and herd immunity will likewise diminish the utility of universal pre-procedural RT-PCR testing.
And my final question, Brad, what is the limitation of RT-PCR testing?
Although we do strongly endorse the use of universal RT-PCR testing, the performance accuracy of available test kits has not been validated in realistic clinical scenarios. Of course, the accuracy in the laboratory setting and in a controlled environment is known. The false positive and negative results in the clinical setting has yet to be reported. Therefore, it's incumbent upon the clinician to interpret the RT-PCR test result in the context of their local disease prevalence and suspicion of infection based on the patient's risks or symptoms against the benefit of the procedural indication. These factors are significant in balancing safety within the GI lab and maximizing procedural access to prevent delays in diagnosis. In summary, although the negative predictive value in our cohort was 99.43% for asymptomatic patients, universal testing was invaluable in preventing 5 unsuspected asymptomatic infected individuals from exposing our ASC personnel to COVID-19. Negative RT-PCR tests allowed for 12%, or 119 patients, to undergo their indicated procedure evaluation, which also offered them reassurance of not having COVID-19. Testing strategies will change over time depending upon disease prevalence, vaccines, and available medical treatments. In the interim, we should adhere to mitigation protocols, including PPEs, hand hygiene, appropriate distancing, and environmental sanitation within our endoscopy centers, and continue to offer RT-PCR testing to maximize safety and procedural access while we await effective vaccine and medical therapies. Thank you for your time, Dr. Vicari.